want to start? It's not starting. How do you start the PowerPoint? How do you start the presentation? It's not.
What do you mean?
Yes, this is what I mean, because I'm not used to.
Okay.
I don't know.
Slideshow.
Oh, yeah. Okay. Now,
good.
here you go.
What time we have the break?
11.
11.
1 hour.
Okay.
Yeah, but we will carry on afterwards.
Yes, okay.
Yeah.
At 11 I stop. Okay,
Yes.
no problem. Good morning. It's a big pleasure to be back in Munich for me. I was here last time in 2017 for the meeting at this night hotel, and I was very happy when Waji invited me for sharing my clinical experience with you. He asked me to introduce myself in details, so that's what I'm going to do. I'm from Brescia, Italy. It's not far away from here. And this is a city known in the world for an historical car race. It was a real car race for 30 years, from 1927 until 1957. Now, every year, we have this race, and it is the best historic car race in the world. Enzo Ferrari used to say that it was the most beautiful race in the world. And this is my father and my mentor, who teach me orthodontist many years ago, and they used to compete with this Lotus in this car race, and I did it once also. Brescia is also a UNESCO heritage site, and this here is the Italian capital of culture. So if you want to come and visit, it's the right year to come because we have a lot of expositions and so on. This is my grandfather. He was probably I think I made some researches about that. He was probably the first Italian dentist going to the US for a dental program back in 1906 and 7. Here he's him in Philadelphia at Penn. And when he came back, he built this building where he put his practice. You can see there his dentist written, and I'm still there. I'm still there in this practice. He bring stuff from there. I have the original Angle book. I have some stuff that he kept from the US, and I still have them. And this is the building after World War II, and now he's like that. So we just made a renovation in 2019, and I also had wanted to take a picture with part of my team at that time. This is my office. It used to be the practice that I share with my father, who was a dentist also. Now my father retired in 2017. So I only do orthodontics. I can only do orthodontics. I cannot do anything else to my patient. So now I have some colleagues coming for surgery and for restoration and so on. This is the waiting room that we have. We have stuff for the kids to play while we wait. We have something for the patient to drink and coffee. This is the room where I practice orthodontics. We have 3 chairs. And I had another 2 chairs for my colleagues, normal chair for restorations, prostheses, and everything, where they can practice. And I also have this consultation room where I just consult the patient for the first time, where I don't need anything special because I only deal with orthodontics and orofacial pain. That's what I do. I had very important people visiting me, as you can see. Dr. Khan and also Dr. Takemoto, who was the inventor of the alias Ormco appliance, the lingual appliance. that I use also. I'm using some cases with aligners, some cases with lingual, and this is my team now, and my boss, who is my wife also. She's the boss. We are perfectly in tune because she commands in the morning and I obey in the afternoon. But I always have the last word, which is, you are right, honey. So it's a perfect relationship, as you can see. Why here? Well, I have a very traditional orthodontic education. I started with the tweed appliance, 0. I went to Tucson, Arizona for the tweed course, and I treated a lot of patients with the 0 appliance. Then I switched to straight wire. And then, because I am a very curious person, I went in 1992 in Indiana for this course. This course was about the differential straight wire mechanics, basically the bag mechanics that G was mentioning a few minutes ago. And he was the inventor of this bracket, and I went there for this bracket. And I went there several times, like 3 times, for different courses. And his father was the inventor of the tooth positioner. So when I went there in 1993, I started using tooth positioners. This was the first lab where the tooth positioner was invented. It was in the garden. And then they built a big company just close to the office, which is TP Orthodontics. TP means tooth positioner, nothing else. And this is a very nice appliance that we are still using. We call it the biomaintainer. It's a silicone appliance, but basically it's a tooth positioner. So I saw at that time, many times ago, that for small movement, tooth positioner were working very well. So when in 1999 I went to San Diego for the AO meeting and I saw this big booth, was the first time that Invisalign put a booth at the AO meeting, I saw this new idea and I thought, it's a series of setups, it's a series of tooth positioning, it's gonna work. So I was confident. I went there and I asked for the appliance in Italy. They told me, no, it's impossible because we have now the CE level and we cannot send you the aligners. So I wait until 2002 in order to have the aligners. But the idea, it was just to move teeth, and this is Wikipedia. And so if Wikipedia says that it's true, okay, more or less. But the history of guidelines is the history of tooth position. The idea was that. And so that's why in 2002, I was the first one using Invisalign in Italy, because I was confident, because I knew that a series of setup and the series of tooth positioner, it would have worked. So this is my Invisalign account, and 20 years ago, in April 2, I sent the first case, and since then I obviously focus my practice on aligners. As I told you, I started with Invisalign. I was invited to Santa Clara, California, where they have their location. I went to San Jose to see where they make all the clean checks, and I was with them until 2008, and in 2008 I stopped giving lectures and courses for Invisalign, and in 2011 I stopped using Invisalign, the aligners, and I helped the Italian company to develop a new aligner system. Here I was at the University of Kuala Lumpur in Malaysia, where we were teaching the students how to use this system. It was called All-In. Then they changed the production. So this is the new company. And this is another Italian company that I use and it is the last Italian company that I use. So I tried different systems, and this was my final destination. Today I want to show you why I think that this system is superior, undoubtedly superior to the other systems. And I have some ideas, clinical ideas that I want to share with you, and I call them my 6 keys to a nice, successful alignment treatment with orthocaps. So I will share you some ideas about diagnosis and treatment planning. Then I want to see with you in details the eye setup review, which I think it's a very important part of the alignment treatment, because it's where we decide if the treatment is going to work or not. Then I want to share you how to properly give instruction to the orthocaps technicians in order to save your time, not the time of the technician, but your time. You know that for me it's fantastic to have the opportunity to change materials during treatment, and I want to share with you the ideas and the cases where and how I'm doing that. Obviously, treatment monitoring is a very important part of the treatment. In my experience, it is not possible to monitor the treatment remotely. I tried some system. I tried dental monitoring. I use it for many patients, but I don't think it's the best way to monitor treatment. It didn't work for me. At least it didn't work for me. And obviously, retention is also a big and important part of our treatment. So we start with diagnosis and treatment planning. The first thing I want to know when I see a case is what's the reason of the consultation, because sometimes I have students who come to my office just to learn something and practice, and they show me some cases, and the first question is always why the patient wants to be treated with you, and sometimes they don't even know, because they have a malocclusion. Malocclusion is not the reason. It's difficult to explain, but I really want to know in the word of the patient, which is the reason. So I have my crooked teeth or a protrusion, I don't like my smile, whatever. So crooked teeth, I want an orthodontic advice, spaces between teeth, she needs an orthodontic appliance. Those are the reasons, that's the most common reason of malocclusion. So, but you have really to be very specific in understanding what the patient wants from you. Otherwise, you can make the best possible treatment, and at the end, the patient is not happy. If somebody comes to you for a gummy smile, and you do not understand that, and you align their teeth and you create a perfect occlusion, and he or she at the end, she still has the gummy smile, she or he is not going to be happy. So the treatment is not successful for me. So that's very important to know and to write. I always write with the patient words the reason for the consultation, and it's the first thing that you see on the PC when I open the page. Another thing is that Wajid told you that aligners work in a very specific way. They are not removable appliances in the traditional way. They are not fixed appliances. They are overlay appliances. So overlay appliances requires, I think, a specific diagnosis because we have with these appliances some difficulties. One is the one that Wajid mentioned, COCR discrepancies. Shift of the mandible. It is difficult to manage a dental shift with the aligners, and Wajid already pointed out that. Very difficult to treat, but not impossible if you use auxiliaries like mini screws, impacted teeth, not easy with the aligners. Rotation of small teeth, if they are small, they are more difficult to rotate, and we'll see it. Extrusions are also considered difficult with aligners. I will show you that we are lucky enough that using orthocaps we can have very nice extrusion, at least in my experience. But translation are still very difficult movement to achieve with aligners. So we will see at the end hybrid aligner treatment for space closure, because the movement of the roots is very unpredictable with aligners. Based on the research that we have, I will show you, it's 5%. 5% is possible to predict the movement of the roots, which is nothing. So the root arthritis is also very difficult. So obviously, if you do not have a proper diagnosis, it's very difficult. You can have a very nice treatment. You have to be realistic with the objective. Do not expect skeletal expansion with a piece of plastic. It's not possible to achieve it. So be realistic and try to have strategies for creating space. I always tell my patient we have only three ways to create space in orthodontics: stripping, expansion, and extraction. Whatever the appliance, to me, there is no difference in the appliance. It's not a problem of appliance. I can expand, I can procline the teeth, I can do stripping, extract. It's not depending on the appliance. It's depending on the diagnosis. It depends on the periodontal support. It depends on other things than the appliance. And anchorage also, it's a very important issue that we are going to cover. And we see that sometimes aligners are not enough, and we need auxiliaries. But we are used to do it in orthodontics. It's not a problem. It's our job. And it's something that it's going to differentiate us as orthodontists from the general practitioners, because we can do treatment with auxiliaries, but at least in Italy, the vast majority of the practices were not doing orthodontics and they're using a liner. They are basically aligning the teeth. That's it. Okay, big alignment. If we want to differentiate us as professional orthodontists, we have to do hybrid treatment and combine different auxiliaries that we know how to use. So my first rule when I diagnose in a case with aligners is to identify the most difficult movement, because this is the limiting step of the treatment. It could be a translation, it could be an extrusion, it could be a rotation, but it is very important when you look at an arch to identify which is the most difficult treatment in the upper arch and in the lower arch, because this is going to guide you throughout the treatment. And then what I want to look to be specific are these issues that we are going to see in details. First of all, teeth shape. Teeth shape is very important, because I told you, we have overlay appliances. So if we have a nice shape, the aligner is going to work better than if we have a bad shape. Like if you have a very small lateral, you cannot expect that the aligner is going to work properly, because there is not enough grip. While if you have a... So it is impossible for me to say, do you use attachment to rotate the lateral? Which lateral? This one or this one? It's different. So you have to be specific and carefully look at tooth shape in order to establish if you need an attachment or not. Okay, and unfortunately, it's only you that can do that. So if you have no grip, you put an attachment. If you have a big lateral and you do not need any more grip, you don't need an attachment. Sometimes it's not necessary to put an attachment. It's not aesthetic, so if you not use it, it's better for the patient. So that's for regarding teeth shape. And that's very important, as I told. With the lateral like this one, you obviously need an attachment if you want to rotate it, because otherwise you have no efficacy of the aligners. And same for teeth dimension. The bigger the tooth, the better the action of the aligners. So think about it. you have a very big, a patient with very big teeth, he is a very good candidate for aligner treatment. If you have usually there are girls with small teeth, very round teeth, they are not good candidate for aligner treatment, no grip. So more attachment. You have to think that in such cases, you have to use more attachment. And you have the option to add some attachment or ask for less attachment. But it's you that have to decide the type and the number of the attachment that you need. Third point, very important regarding the dimension of the teeth is also the stripping. Well, Jim mentioned the stripping, which is a very common part of orthodontic treatment. I used to be, and I am maybe a lazy orthodontist. So in the past, I tried not to use stripping because it was time consuming, it was an effort. So for me, for a long time, it was either extraction or expansion, okay? Now, it's like probably 10 years that I'm using more and more stripping, which is probably the best way to create space in the arch. Not depending on the appliance, talking in general, because the worst thing that we can do, and we'll see it, it's just expansion. We're pushing the root out of the bone. That's the worst thing that we can do for our patient. So stripping is very important, but we also have to look at the proportion of the teeth, because sometimes you have patients who are not good candidates for stripping. We know that we have a specific proportion of the teeth to maintain, and the best one is when the upper central is wide 80% compared to the height of the teeth. That's the ideal proportion. So if we think about it, we have candidates for stripping and others who are not candidates for stripping. The patient on the left side is not good for stripping. She has very long and narrow teeth. The other one, this one has very wide teeth. So you have to think about it. You cannot expect a dental technician of any company to look at that. They just look at the space, if they need space or they don't need space. They don't look at this kind of proportion, golden proportion. That's only you that can do that. So be very careful if you can accept or require stripping in a certain patient, okay? Remember, you have the choice to ask for expansion or to ask for stripping or to ask for extraction. It's your choice, but it's a diagnostic choice in my opinion. It's not a problem of appliance, it's a problem of diagnosis. So it's up to you. You can request less or more stripping. You will be, when I show you some cases, I'm very specific. Sometimes I tell the technician where I want them to do stripping and where I do not want to have stripping. If I have small laterals, I write, I don't want you to make stripping on the laterals. Otherwise, I know that when I see the setup, I see stripping on the laterals. If they are already small, I don't want to get them smaller. So you have to tell the technician where you want to do the stripping. That's very important. Teeth position is also very important. If you start with a good position, do not change it. Sometimes we have perfect occlusion on one side, a bad occlusion on the other side. So tell the technicians, do not move these. I want to just keep it the way it is. And aligners are the best appliance to do that. When I was using straight wire or other appliance, I was putting the brackets. Always it was like, I will be so good at the end to have the same perfect occlusion. Hope so. With aligners, you know that you can keep it perfectly stable if you just tell the technician do not move well. So that's one of the things that I like the most of aligners. I can keep what is good. So just use this icon and put where you do not want them to move the teeth. That's a very useful part of aligner treatment, and I use it a lot, okay, especially on the posterior teeth, if there is a nice occlusion, I ask the technician not to move them, just to be sure. Like in this case, you see, very nice occlusion, small diastema, lock occlusion, very easy. If you have a perfectly seated occlusion or TMD patient, periodontal patient, high angle patient, in all these cases, I prefer to maintain the occlusion as it is without changing it. Especially in high angle cases, you will see aligners are fantastic appliances because they allows us to perfectly control the posterior vertical dimension. To avoid posterior extrusion, it is very important in high angle cases. And there is nothing better than an aligner, and there is nothing better than thick aligners like the nightcaps that we use. The thick nightcaps are fantastic in order to maintain the vertical dimension in the proper position. So, and also, this is a good point, differences in tooth shape and dimension. If you look carefully to your patient, you will see that very often we have differences in size from one side to the other. Let's see this example. If you look carefully at the mesodistal dimension of the central and the lateral incisor, you will see that while the upper right lateral is 7,25 millimeters, the left one is smaller. See, at the beginning. When I received the first eye setup, that was the stripping distribution that they proposed me. Because they are technicians. And I'm not lucky as you are. Because what he told me, I'm not looking at your cases. You are experienced, I'm not, so he's not looking at my cases. At least he's looking at your cases, but not at mine. So that's why I'm very careful, and that's why I will show you I'm very specific with technicians. But if I have a wider lateral, I want to reduce this lateral. So what I told them is just, I want to reduce this lateral. Very easy. I changed the distribution because I had different medial-distal dimension of the two laterals. But again, it's only you that can take care of these maybe small things, but it is important if you want to have an excellent result at the end of treatment. Rotations. That's something I'm dealing with exceptional result since I use the orthocaps, and it's something I'm lecturing a lot in Italy about because my experience with rotations with different aligners, and it's totally different since I use orthocaps, because in the literature we know that there are movements that are considered very difficult with aligners. And rotation is one of these movements because normally, there is no undercuts to rotate a round tooth. There are microcollision, a lot of problems with rotations. But I think when you have to rotate a tooth, it is very important to evaluate the anatomy, as I told you, and of the crown, because the bigger is the tooth, the easier is to control the rotation. Again, like with these laterals, it's completely different. Another question you have to ask you is the rotation it's needed to correct this particular rotation. Like in this case, as you can see, there is a perfect occlusion, and the upper second premolars are rotated. Are you going to rotate those teeth? I'm not. There is no reason to do that. So I tell the physician, I don't want you to rotate those teeth. There is no functional need, there is not aesthetic need, there is no need to do it. So if there is no need to do it, just don't do it, okay? So keep it as it is. You cannot have a better occlusion than that. Forget the rotation. So if there is no need to do it, just forget it. Another question is, do I need something, some auxiliaries to rotate, or I can do it with aligners only? Like in this case. Or sometimes I have to use auxiliary treatment in order to rotate teeth, and we will see it later. I want to share with you this analysis of the literature that they made. It appeared in February last year on the World Federation of Orthodontic Journal. And it is a nice review. And I like very much this graphic because it's very clear. So what we understand from this review is that the best movement is tipping, okay? Tipping has an 80% efficacy with aligners. Not 100%, 80%, even tipping. Then we have movements who are above 50%, which is not bad, and they are the intrusion of the posteriors and the rotation of the incisors. And this is not bad, okay? It's over 50%. Then we have some movements that are not working very well, which is rotation of cylindrical teeth and extrusions. So that's not easy. And also intrusion of the anterior teeth. And then we have very poor movements, where the aligners are not able to produce a predictable movement. Root movement is 5%, which is almost nothing. But at least now I want to forget root movement. We will see root movement later on. Now we want to just to see what the literature consider in between the 50%, more or less the 50% of predictability, around 40. So extrusions and rotations. For extrusion, the efficacy is in the literature 35%, which is very low. And the rotation of cylindrical teeth and intrusion of the anterior teeth is 40%. We see that the lower cuspids are a very difficult teeth to control with aligners, and that was for me in the past. But what I want to show you now, I'm changing my advice, and I have no problems with rotation. I have now a student who is coming in my office, and I spoke with her dean in order to have a thesis about that. I would like her to study my cases, because I'm pretty sure that we will find a number very difficult from the one that we have in the literature. I have no time, and I've told you I'm lazy. I don't want to do the research myself. But if someone, I invited several universities to do it, and I hope they're going to do that. So this is a nice case, very easy. It is probably the first case that I treated with orthocaps, and I was at that time very happy. This is another case. And it is still a very good rotation. This is Isabella. He came to the office because of crooked teeth. She was not cooperating very much, and that's the reason we use more aligner than what it was probably needed, but she was not a good patient. Still, we had a very nice result, as we will see. So when this is Isabella at the beginning of treatment, so please look at the lower cuspid. They are considered to be difficult to treat with aligners. Obviously, you have to use the proper attachment, which is maybe important, but most important, the proper material, the proper elastic material, as Wajid mentioned before. we had a problem with the lower left third molars, so as to extract, and I told the patient that it would probably be necessary to use an auxiliary treatment with fixed appliances in order to keep these molar into the occlusion. But I was lucky enough, I had not to do that, so the molar came into occlusion without any auxiliary treatment. But I was smart enough to tell the patient, remember, whatever you say before is an explanation. Whatever you say after is an excuse. So tell the patient everything in advance. I invest a lot of time before treatment with the patient. I speak with them like 45 minutes when I present the treatment plan, and I cover every aspect. I want to be sure that everything is clear. But in this way, I've been practicing for 35 years without any problem, because everything is clear from the very beginning. So sometimes you can fail, sometimes you can still have excuses, but very little times. So this is the upper arch, and this is the lower arch. So again, look at the lower cuspid. I'm doing nothing particular. I'm just using the right aligners, and Wajid is using the right materials. And there is no secret. I mean, you have to create space, of course, and just to keep the aligners and ask the patient to wear it as much as they can. So then this is a research from a German team, my friend Jörg Schwarze. I know him since the beginning, because we were Invisalign used to make these speakers meeting every year in different locations in Europe. So I know him since long time, and he did this nice research where they saw that premolar derotation is also considered very difficult with aligners. And that's the reason why I see in the journal some articles where they publish that for a rotation of a premolar 31 degrees, you need auxiliary treatment. Look at that premolar and look at this premolar. No auxiliary treatment. The problem was that I was so concentrated on the front side that during treatment, I didn't even look at that. And at the end of treatment, I looked at it and said, that's crazy. I mean, that's a fantastic rotation, but I wasn't even looking at during treatment, because I was so, we will see this patient at the end of the day, but that was amazing in my opinion. Okay, this is again about rotation greater than 15 degrees, and extrusion are considered very difficult or impossible with aligners. This is another article 5 years ago where they saw that all the rotation were significantly smaller than those predicted. And I have now a different perception of the problem because even canines and premolars, if you use the right materials, can be rotated in a very good way. This is again a treatment, an auxiliary treatment published for rotations, and I want to share with you the case of Alessandra. I always put now the stages that we need. We have twin aligners, you know, so they have to fabricate the double overnight, but we don't care. We just, as clinicians, to me, what is important is the number of the stages that we use. So the time that I need. I in the past had cases with 110 aligners in the upper, not with orthocaps, and aligner and 10 in the lower, which is crazy for me. It is crazy when somebody tells me, oh, but they send me aligners for 5 years for free. Not for free, for the original price. I say, it's crazy. Do you really want do you really want a line for 5 years? Do you really want to treat a patient for 5 years? I don't. I want to finish the case reasonably in 2 years. Otherwise, there is no profit. And those guys who are treating and tiring the patient with aligners with 80, 90, 100 stages, that's crazy. So that's why I put stages. Those are the stages that we use, 30 stages. Which is normally more than the original predicted, but still is not enough. Still is 30 stages. I'm now routinely change the aligners every 2 weeks, rarely now every 3 weeks, routinely every 2 weeks. So 30 stages is 60 weeks. It's 1 year. It's reasonable. Look at that. Please look at tooth number 33. Please look at 33, which is, okay? And we also have premolars. So here we have all the rotation that we need. It was a 10 steps duration phase, stripping in both arches, and attachment for the rotation. Nothing more, nothing special. But what is special is very elastic materials. Those very elastic materials that can rotate the teeth. This is the upper arch, and this is the lower arch, which is simply amazing. I mean, I don't think any other, I'm not here to promote, we are friend enough. I do not have to promote orthocaps. I mean, I don't care. But I think, I was amazed. I simply was amazed. So that's why I'm searching for someone who wants to study this, because I'm pretty sure that treated in the proper way, with the good treatment monitoring, the good stripping protocol, if the stripping is done as prescribed, okay, we have to mention that all these aspects are important. But then the aligners are very efficient. So, sure.
What was the plan with the wisdom teeth? Did you left them just as they are, or
Yes, I don't remember the particular case. By protocol with the wisdom teeth, if it's necessary to extract the wisdom teeth, I tell the patient or the parents that we have to extract it. If they refuse, I have the American Association of Orthodontics form that they can sign and keep the wisdom teeth. I normally tell the patient the reason to extract the wisdom teeth is not an orthodontic reason. I can treat the patient even with the wisdom teeth. You have to extract the teeth even if you do not do the orthodontic treatment, because there is an indication to do that. You don't want to do it, fine, just sign, and I continue the treatment. I don't remember in this particular case, but that's my routine. So this is before and after. And the only answer that I have is elasticity. I cannot find any other answer. It's not the attachment, it's the elasticity. And
there's one more thing.
Yeah.
That's the secret. Nobody knows.
Okay. Tell us the secret.
No. I think one of the factors is that, in regular aligner staging, the way teeth are moved is they move the crowns only. So if you have software like Onyx or 3Shape, they move the crown. What orthocaps does is we create virtual roots on every tooth. So we take into account the whole length of the tooth. And this has a very big effect on the rate of movement of the teeth. So if we are putting actual